Hello everyone. Today we are going to learn about chest radiography. There are few imaging modalities of chest radiography. First one, plain radiography of the chest. There are basic projections and special projections, and CT scan of the chest. Then MRI of the chest, nuclear imaging of the chest, and PET scan of the chest. It means positron emission tomography and SPECT ultrasound scan. Positioning terminologies. Posterior anterior projection or PA projection. With erect position, patient's anterior aspect of the chest contacts the erect bucky surface. Central ray enters the chest through the posterior aspect of the chest and exits through the anterior aspect. Anteroposterior projection, AP projection. With erect or supine or semi-erect, when the patient's posterior aspect contacts the erect bucky surface or tabletop or a grid or normal cassette. Central ray enters the chest through the anterior aspect and exits through the posterior aspect of the chest. You can see these radiographs. Then the lateral projection. This is named according to the side of the chest nearer to the image receptor. When the patient's right side is closer to the image receptor, it is named as right lateral projection, and when the patient's left side is closer to the image receptor, it is named as left lateral projection. Patient and the equipment preparation. Patient preparation. Ensure that all metal objects in the chest region are removed from the patient. Ask the patient to remove all the clothes in the chest region, and if the patient is a lady, provide a jacket or a gown to wear. The patient should be provided with a clear explanation of any movements and image receptor positions associated with the technique. Patient should be instructed about the breath hold while during the exposure. Use appropriate radiation protection measures for the patient. Example, use gonadal shields and eye goggles. Then the equipment preparation. Select the suitable cassette size according to the size of the patient. Usually 30 to 40 cm or 35-35 cm is used. Attach the lead name blocker, side marker, date, patient ID on the cassette or bucky surface. Ensure it will not interfere with the final image. Place the cassette correctly in the erect bucky or table bucky in longitudinally. For the skull radiograph also, we insert the cassette in longitudinally. For the chest radiograph also, we use longitudinally. Prepare the X-ray tube according to the examination. FFD 120 cm. FFD 180 cm for the PA and 150 cm for the lateral. For AP we are using maximum possible distance. Again, FFD for PA 180 cm. For lateral 150 cm. For AP maximum possible distance. Prepare the other useful accessories such as immobilization devices. Select the exposure factor factors correctly according to the examination and the patient size. Then, radiation protection measures. For the patient, avoid or minimize the repeat examinations by identifying the patient correctly, giving a proper explanation about the procedure to the patient, immobilizing the patient if needed. Select the optimum exposure factors according to the size of the patient. Follow the LRR principle as low as reasonably achievable principle. Provide leg protective things such as gonadal shields, eye goggles. Whenever possible, use PA rather than AP technique since this vastly reduces the dose to the thyroid and thymus. In the skull radiograph also, we use PA position because to reduce the eye dose. For in that chest radiography also, we use PA position to reduce the radiation dose to the thyroid and thymus. Collimate the beam properly to the area of interest. If the patient is a lady, especially in the childbearing age, ask about the pregnancy. Follow the 28-day rule if the pregnancy is suspected. For the radiographer, stay inside the lead cubicle while doing the exposure. For the guardians, provide a lead apron, thyroid shield and eye goggles if available. Okay, then now we are moving to the PA radiograph. What are the indications? Pathological conditions in the chest. Example, pneumonia, pneumothorax, pleural effusion and trauma. Position of the patient and the image receptor. A 30 to 40 or 35 cassette is placed longitudinally in the bucky tray. The patient is positioned erect with the anterior aspect of the chest is contacting the bucky surface with the chin raised. The feet are placed slightly apart so that the patient can remain steady and the pelvis should be symmetrical. The median sagittal plane of the chest region is adjusted at right angles to the bucky surface and it should be coincident with the midline of the bucky surface. The shoulders are rotated forward and pressed downward in contact with the bucky surface. To move the scapula laterally away from the lung fields, we can obtain this by positioning the posterior aspect of the hands behind and below the hips with the elbows brought forward or position the arms to encircle the bucky. Okay, you can further understand by looking at these pictures. The shoulders are rotated forward and pressed downward in contact with the bucky surface to move the scapula laterally away from the lung fields. We can obtain this by positioning the posterior aspects of the hands behind and below the hips. Okay. Then direction and centering of the X-ray beam. The horizontal center beam CR is perpendicular to the image receptor is directed to the midline at the level of 8 thoracic vertebra. Okay, the horizontal center beam is perpendicular to the image receptor and it is directed to the midline at the level of 8 thoracic vertebrae just below the inferior angles of the scapulae. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the horizontal center line of the primary beam, and position of the cassette should be adjusted if needed. Collimate the beam superiorly 5 cm above the shoulder joint to allow proper visualization of the upper airways. What is? Collimate the beam superiorly 5 cm above the shoulder joint. Okay, to allow proper visualization of the upper airways. Inferior to the inferior border of the 12th rib and lateral to the level of the acromioclavicular joints. Again, collimate the beam superiorly 5 cm above the shoulder joint to allow proper visualization of the upper airways. Then inferior to the inferior border of the 12th rib and lateral to the level of the acromioclavicular joints. Exposure is made in full arrested inspiration. Then, essential image characteristics. Full lung fields with the scapulae projected laterally away from the lung fields should be seen. What? Full lung fields with the scapulae projected laterally away from the lung fields should be seen. The clavicles are symmetrical and equidistant from the spinous process and not obscuring the lung spaces. The clavicles are symmetrical and equidistant from the spinous processes and not obscuring the lung apices. The lungs are well inflated. It should be possible to visualize either 6 ribs anteriorly or 10 ribs posteriorly. 6 ribs anteriorly, 10 ribs posteriorly. The costophrenic angles and diaphragm should be outlined clearly. The mediastinum and heart should be in center and defined sharply. The fine demarcation of the lung tissues should be seen from the hilum to the periphery. This is a radiograph. Okay, now we can check the image characteristics. Full lung field with the scapulae projected laterally away from the lung field should be seen. This is the lung field. The scapulae, you can see scapulas are projected laterally away from the lung field. Okay. Then the clavicles are symmetrical and equidistant from the spinous processes and not obscuring the lungs apices. The clavicles are symmetrical and then equidistant from the spinous processes. Okay. Then the lungs are well inflated. You can see lungs are well inflated. And it should be possible to visualize either 6 ribs anteriorly or 10 ribs posteriorly. We can count the ribs. Okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, anteriorly and posteriorly. Okay. Okay, then the mediastinum and heart should be in the center and defined sharply. You can see the heart. Common faults and remedies. Fault: rotation of the patient. Appearance: the clavicles are not in symmetrical position and there are not equidistant from the spinous processes. Remedial action: attention to how the patient is made to stand is essential to ensure that they are comfortable and can maintain the position. Legs should be well separated and the pelvis symmetrical in the respect to the vertical bucket. Second fault is insufficient breathing. Appearance: lung feet are not well inflated, can't see the maximum number of breaths. Remedial action: explain the rehearsal of the breathing technique before exposure. Third fault is patient is off-centered. The vertebral column is shifted into one side of the radiograph. Remedial action: check the medial sagittal plane positioning. MSP should be coincident with the midline of the bucky surface. Okay, now we are moving to the anteroposterior AP radiograph. Alternative to the PA for infants and children, it means 1 to 4 years old, for invert patients and for the situations where PA is not possible. For infants and children, for invert patients and for the situations where PA is not possible. Positioning of the patient and cassette. The patient may be in the standing, sitting, lying supine or semi-erect position with the back against the image receptor. Erect bucky surface with the upper edge of the image receptor is above the lung apices. The MSP of the chest region is adjusted at right angles to the image receptor or erect bucky surface, and it should be coincident with the midline of the image receptor or erect bucky surface. Shoulders are brought downward and forward, which has the effect of projecting the scapulae clear of the lung field. Chin should be elevated. Direction and centering of the X-ray beam. CR is perpendicular to the IR and it is directed towards the midline at the level of the sternal angle. When the semi-erect position is used, a beam angulation is required to direct the CR perpendicular to the IR. CR is perpendicular to the IR and it is directed towards the midline of the level of sternal angle. This is for AP projection. Okay, now we will move to the PA projection. In the PA projection, CR is perpendicular to the IR and it is directed to the midline at the level of the 8th thoracic vertebrae and just below to the inferior angles of the scapulae. Just below to the inferior angles of the scapulae, midline of the 8th thoracic vertebrae. 8th thoracic vertebrae. Okay, this is for PA projection. Now, for AP projection, CR is directed towards the midline at the level of the sternal angle. Midline at the level of the sternal angle. When the semi-erect position is used, a beam angulation is required to direct the CR perpendicular to the image receptor. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the center line of the primary beam, and position of the cassette should be adjusted if needed. Collimate the beam properly. The exposure is taken on full inspiration if possible or otherwise expose when the patient's chest wall is rising up. The exposure is taken on full inspiration if possible or otherwise expose when the patient's chest wall is rising up. This is full inspiration for the AP Then for the PA, we used full arrested inspiration. Okay. Look at these images. This is AP projection. Now, essential image characteristics. Full lung fields with the scapulae projected laterally away from the lung fields should be seen. This may be not seen with the infants, trauma or invert patients. Full lung fields with the scapulae projected laterally away from the lung field should be seen. This may be not seen with the infants, trauma or invert patients. The clavicles are symmetrical and equidistant from the spinous processes and not obscuring the lung apices. This may be not seen in infants, trauma or invert patients. The lungs are well inflated. It should be possible to visualize either 6 ribs anteriorly or 10 ribs posteriorly. This may be not seen with infants, trauma or invert patients. The costophrenic angles and diaphragm should be outlined clearly. The mediastinum and heart should be in center and defined sharply. The fine demarcation of the lung tissues should be seen from the hilum to the periphery. Okay, this is a AB projection. Then you can see well the ribs are somewhat not similar to the PA. Okay, now I will show the PA. This is PA radiograph. You can see the ribs are like this. This heart is very clear. Okay, then lateral radiograph. What are the indications? As a complementary view to PA or AP view for localizing the position of a lesion. To decide the depth of a lesion which is extended anterior-posteriorly. To decide the depth of a lesion which is extended anterior-posteriorly. Position of the patient and cassette. The patient is turned to bring the site under the investigation in contact with the erect buccal surface. MSP is parallel to the image receptor. The arms are folded over the head or raised above the head to rest on a horizontal bar. You can see this. The mid-axillary line of the site to be examined should be coincident with the midline of the erect buccal surface. The mid-axillary line of the site, to be examined should be coincident with the midline of the erect buccal surface. Direction and centering of the X-ray beam. Direct the horizontal center ray, a perpendicular beam to the image receptor, to a point on the mid-axillary line of the unexamined site at the sternal angle level. Again, direct the horizontal center ray, it is perpendicular to the IR, to a point on the mid-axillary line of the unexamined site at the sternal angle level. To a point on the mid-axillary line of the unexamined site at the sternal angle level. The position of the cassette should be checked to confirm whether the center of the cassette is coincident with the horizontal center line of the primary brain, and position to the cassette should be adjusted if needed. Collimate the beam properly to the region of the interest, superiorly 5 cm above the shoulder joint to allow proper visualization of the upper airways, inferior border to the 12th rib, and antero-posterior to the level of the acromioclavicular joints. The exposure is taken on normal full inspiration. Okay, you can see these images. This is a lateral radiograph of the chest. Alternative method for lateral chest X-ray image. Lateral dorsal decubitus. This one. This is an alternative method. Lateral dorsal decubitus. Okay. Now the lecture is finished. Thank you everyone. We will meet with another interesting lesson with next video. Bye bye.